consider is a time-limited trial. So sometimes we'll talk about this with families, but I think it's really important to discuss, we'll try intubation because we think that might give the lungs time to heal. Here are the things that we would be looking for in the timeline we would expect that to happen in. And then establish clear parameters and timelines in advance, only if you think it has a reasonable chance of helping and you're not just trying to do something to do something. And then consider making a specific recommendation. And your recommendation might be as part of a team. You might say, I don't see any further benefit from doing this because here's what's been happening when we give this treatment. But then that allows the team to give a good picture to the family of what's going on. This is another picture of Maggie. Children and adolescents, so they often rate their symptom burden and quality of life much differently from parents or healthcare providers. So how do you think they rate their symptom burden? Higher or lower than what their parents think? I hear some lowers. Okay, how do you think they rate their quality of life? Yeah, so they actually rate their symptom burden higher. So in group settings. So in individual settings, some will rate lower. But in groups, they rate their symptoms higher, but also their quality of life higher. So they're willing to put up with a lot, but they would sure like us to treat their symptoms as well as we can. But oftentimes they feel like they have a pretty good quality of life even when healthcare providers don't see it that way. They may or may not want to be involved in various parts of the healthcare discussion. So we have to ask, and then we have to listen. So even teenagers sometimes are like, I don't want to know all that information. Please, share that with my parents. Let my parents, decide. Or you can ask me if I want to be part of this specific decision, but I may or may not want to be. They can suffer from isolation, guilt, or uncertainty if they feel like a topic is taboo and nobody's talking about it. And that can be the way it is with death often. Like everybody thinks that they don't know that they might die or that they don't know that they have this diagnosis. But oftentimes they really do. I mean, the internet, right? People can figure things out now. But if nobody else is talking about it, they oftentimes don't want to bring it up. So they benefit from controlling at least certain aspects of their care, having the opportunity to ask questions, and the opportunity to give gifts to their family. Some children, like at Christmas, have said, I want to give my books to this friend, and I want to give my stuffed animals to that friend. And I mean, that gives them an opportunity to show generosity. That's one of the gifts we can give them. So I want to talk a little bit about symptom management, and I'm going to focus on dyspnea and secretions. So dyspnea is a subjective experience of breathing discomfort. I won't read over all of this slide, but secretions, especially problematic for many of the kids I follow with neurologic conditions, which makes me gag when they gag. So those are the symptoms. There are non-pharmacologic treatments and medical treatments. So for dyspnea, making sure that the room smells as good as it can smell. Sometimes elevation of head of bed or positioning, a fan, relaxation techniques to help them when they get anxious, and then that makes the dyspnea worse. And then medical treatments. And the one I'm going to focus on is opioids, because that's often one of the later lines. And especially at end of life, people get uncomfortable with it, especially doctors, and they think, I don't want to give opioids because it might hasten death or they might die. So if you give opioids at the right level, and oftentimes if it's just dyspnea you're treating, it's a lower dose than required for pain management. It usually makes people feel more comfortable and breathe better than they would otherwise, so it typically does not hasten death even after compassionate extubation. So I think it can be a really good technique for us to utilize appropriately. I'm running low on time, so I'm going to kind of keep moving. For secretions, what we typically use in pediatrics is glycopyrrolate, because we have a lot of patients on that anyway. But the other thing for secretions, especially if it's at end of life, is to turn them to their side. So if they're having that sound that people sometimes call a death rattle, it usually is not helpful to go after it with deep suction, because that just might be more traumatic, but putting them on their side, letting the parent hold them, explaining to the parent that their face is calm, so it's not bothering them. It's a normal part of the process. Their body is doing everything just right, just the way it needs to do, and we all need to relax. That's what I try and tell the medical team and the parents. So these are some of the places where palliative care for pediatrics is available in the state. So Blank has a children's team, ChildServe offers palliative care, and we work with hospices across the state. Here are some tools for consideration. So everything from conversation guides for families to be able to talk with their kids to some advanced care planning sets. I'm going to talk a little bit about iPost. Is everybody familiar with iPost? Raise your hand if you are familiar with iPost. Oh, not everybody. Okay. So iPost is Iowa Physician Orders for Scope of Treatment, which can be filled out by a nurse practitioner or a PA. So I don't know why we called it physician orders, but they didn't ask me. So it's intended for individuals who are frail and elderly or have a chronic critical medical condition or a terminal illness. And I like to say frail and complex, because my kids aren't elderly, but they're complex. Or they're frail and frail, I don't know. And this is a way of transferring medical orders from one setting to another. So for our kids, it could be in daycare, it could be in their long-term care facility, or in the hospital, or at dialysis, and it reflects a discussion that was had with their healthcare team and their wishes. But it can be revoked or changed over time if need be. So this is what the form looks like, and it's this jam and salmon color over here. So it gives you the option of attempting CPR or not attempting CPR if there's no breathing and the heart has stopped. But if something is going downhill but we haven't gotten to cardiopulmonary arrest yet, you can focus on comfort measures, limited additional interventions, which basically means do things to help me out, but don't intubate me and put me in the ICU, or full treatment, which means intubate me and put me in the ICU. And then there's a section on artificially administered nutrition. So this is something that EMS is aware of. So if EMS gets called to a home and somebody has like a DNR, limited additional, then they could help family follow those wishes even for a child, since children don't have out-of-hospital DNR. And we have filled these out on almost 100 kids in Iowa. I think somewhere on here it says, so 35 DNR comfort, but some of them wanted CPR full treatment, and they just wanted people to know that, so they can go to the ER and not get the, do you know your kid has trisomy 18? Do you know that trisomy 18 is incompatible with life? Well, not with my 5-year-old, she's doing okay with trisomy 18. So yes, I do want her to be full code and full treatment. So families use these for a variety of reasons, and Sheila Frost from our team provided me with these slides, and these are where the kids that we know who have iPosts are around the state. All right, and then concurrent care hospice, all I'm going to say about that is that kids should be able to get hospice care and life-prolonging or disease-directed therapy at the same time. Here are some resources. We have a November 15 conference coming up in this very same room. If anybody is interested, let me know. There are some websites that I left for you, including courageousparentsnetwork.com, which is a great way of listening to family stories about how they made decisions and how they lived with challenging healthcare conditions. And that's it, but I don't know if I left time for questions. So the difference between a living will and an iPost is that a living will is an advance directive where you say, if I'm in a state where I can't make my own decision and I meet the specific criteria of the living will, which is that my doctors say I won't be able to make my own decisions again, then I don't want life-prolonging treatments. Whereas the iPost can be in effect while you're still able to make your own decisions, or if you're a child or someone with dementia and somebody else is making decisions for you.
Any other?
If you shout it, I'll repeat it.
Do you have a mechanism for working with families with, say, a trach patient
So is there a mechanism for working with a family who the patient has a trach and they can't get nursing staff in the home? That's been a big challenge recently. So there are a lot of patients who have a trach, could be at home if they had nursing support. I don't necessarily have any other ideas about that. We've let some families go home if they have extended family support and they have like 3 or 4 caregivers trained who can provide some time for the parents to actually sleep. We've used some other facilities around the state to temporize, but
It seems to me like some of those families, you know, the kids med with the IV, and maybe they get tube feeds during the day and everything else. And I wonder why home care companies are reluctant to staff those kids with respiratory therapists with this nursing shortage, and it's just not happening. And I just wonder if that's been happening.
maybe we'll have to talk after this. Give me your ideas.
Any other questions? All right.
Okay,
Well,
thank you.
Thank you very much.